Hi, my name is Cynthia Wu, and I am a neuroradiologist at Emory University, subspecializing in head and neck radiology, and I'm going to spend the next half an hour or so talking about cervical lymph nodes. I have no relevant disclosures. So we're going to start by defining the cervical nodal levels in order to help you facilitate your communication with your referrers, including your ENT surgeons. We're going to discuss some special nodes that are not really located within levels, but are important nonetheless to be able to identify so that you can see them when there's pathology in those areas. And we're going to go over classic nodal drainage pathways from various aerodigestive tract subsites so that if you see a cancer in one of those subsites, then you can kind of look in those nodal levels in order to identify any potential nodal metastasis. Then we're going to go over what really constitutes nodal pathology in the head and neck, what makes it considered bad, quote unquote. And we're going to quickly go over and review nodal staging for head and neck cancer according to the AJCC8 criteria. And finally, look at some causes of cervical lymphadenopathy other than head and neck squamous cell cancer metastases. So let's start by going over nodal levels. We have a drawn schematic on the right here, and then we're just going to look at axial MRI images to illustrate each of these levels. We will start up high, just above the level of the hyoid. You in fact see parts of the hyoid right here to orient us, right? We have an axial image right here, and we're essentially at the level of your vallecula right here, and here you see portions of the epiglottis. Now, when we look at this area highlighted in pink, which is located anterior to the hyoid and medial to the anterior bellies of the digastric muscles, shown here, that is going to be your level 1A lymph nodes or the submental lymph nodes. These nodes are located below the floor of mouth, below the mylohyoid sling, and again, medial to the anterior bellies of the digastric muscles. Lateral to that, you have your submandibular space and your submandibular lymph nodes, otherwise known as your level 1B lymph nodes. That's equivalent to this area right here. You see that this area includes your submandibular gland, the posterior margin of which can be used as a delineator between level 1B and level 2A. But in fact, a more accurate landmark would be the posterior belly of the digastric, which is not shown very well on these images. Again, these are your level 1B or submandibular lymph nodes. As you move posterior to that, you have your level 2A lymph nodes. These are your classic jugulodigastric chain nodes. They are often a little bit larger than the rest of your neck nodes, even in a normal young patient. You can see that over here, I used the posterior margin of the jugular vein to separate your level 2A and your level 2B lymph nodes. Typically, in the surgical literature, we're going to be using the spinal accessory nerve to delineate level 2A and level 2B. But on imaging, we're really not going to see that as well as the posterior margin of the jugular vein. So now that we've gone over these areas, let's look at the posterior triangle of fat here, which is going to be the very top of your level 5 lymph nodes, belongs to the level 5A portion, and what delineates it anteriorly is going to be the posterior margin of the sternocleidomastoid muscle, shown here, and behind that area you're going to be outlined by the anterior margin of the trapezius right here. So these are your posterior cervical triangle or level 5 lymph nodes. As you move a little lower, below the body of your hyoid, we're now moving into level 3 lymph nodes. So what defines or separates level 2 and level 3? That would be the body of the hyoid. So here you see that I've highlighted on the axial images level 3 lymph nodes. Again, anterior border, you have your infrahyoid strap muscles bordering that, and then posterior to that, you have the posterior margin of the sternocleidomastoid again. And behind that, you again have your posterior triangle, level 5A lymph nodes. What about that space which is in between the carotid sheaths bilaterally and surrounding the aerodigestive tract? Those are going to be your central compartment or level 6 lymph nodes, and that's shown here in orange. As you move a little lower, now we are below the level of the cricoid. Inferior to the inferior margin of the cricoid, we now have level 4. Again, the inferior margin of the cricoid is what separates level 3 and level 4, as shown on this drawn schematic. Your level 4 lymph nodes are your most inferior jugulo-digastric chain lymph nodes. And again, posteriorly, it's bounded by the posterior margin of the sternocleidomastoid muscle. Behind that, you again have your level 5 lymph nodes. Because we're now below the inferior margin of the cricoid, these are now level 5B lymph nodes. In your central compartment, we again have level 6 lymph nodes. Sometimes people will refer to them as these peritracheal lymph nodes, as their, or maybe even tracheoesophageal groove nodes, and these are all considered central compartment or level 6 lymph nodes. What about nodes outside of those prescribed cervical levels? Well, we have preauricular nodes or periauricular nodes, those lymph nodes that are located surrounding the external ear or auricle. We have intraparotid lymph nodes. The parotid glands are the only major salivary glands which will contain lymph nodes within them. So we will make sure to pay attention to those. Posterior cervical nodes, that is usually located in the subcutaneous regions in the posterior cervical region. We'll see examples of that. And as well as retropharyngeal nodes and preclavicular nodes, which are technically really inferior level 6 nodes, but they're important because they're easily missed due to streak artifact from surrounding bony structures. Here I put supraclavicular nodes in parentheses because these nodes used to be important when we're talking about head and neck cancer staging, but now in the HACC8 criteria, they're no longer used. Part of that is because on imaging, it's really hard to say what's technically a supraclavicular node. Sometimes folks will say that if you can see the clavicle on the same image and you see a node on that axial level, you can call it supraclavicular node. Well, that's going to change quite a bit depending on whether the patient is positioned with their arms up or arms down. So now we can still use it when we see a node with just above the clavicle in the supraclavicular fossa, but really those nodes are more accurately referred to as inferior level 4 or inferior level 5 lymph nodes. So the first three, periauricular, intraparotid, and posterior cervical nodes are important because if you see those, you should think about the potential that there are Mets from a cutaneous primary malignancy. It is rare for a primary head and neck cancer to metastasize to those lymph nodes. So again, when we see nodes around the ear, inside the parotid, and in the posterior cervical subcutaneous soft tissues, we want to be thinking about a skin or maybe scalp primary malignancy. So let's see some examples. Here we have a FDG PET study with a accompanying CT, and you can see that anterior to the left external auditory canal, we have an FDG avid lymph node that is also rounded in appearance. And this indeed is a pathologic preauricular node in a patient with a history of a scalp squamous cell carcinoma. Here we see a few findings. We see a large ulcerating skin lesion on both the axial and coronal images just below the external ear on the right. And you also see a necrotic appearing heterogeneous lymph node within the right parotid tail. So this is an example of an intraparotid node. There is an additional metastatic nodal lesion just inferior to that, but really, again, these are examples of an intraparotid and neck nodal metastases from a primary squamous cell cancer of the skin. Here, in a patient with lymphoma, where we see scattered rounded pathologic nodes in both necks, we have an example of a posterior cervical lymph node, which is also enlarged. This is a example of a retropharyngeal lymph node. You can see that it is very T2 hyperintense and abnormal. And in fact, this is from a palate primary head neck cancer and with metastasis to a retropharyngeal lymph node. You can see that it's located medial to the carotid sheath and in the lateral retropharyngeal space. What about here? This is that very inferior central compartment level 6 lymph node that we were talking about. It's a rounded preclavicular node, meaning that it's just medial to the head of the clavicle as you look inferiorly. And when these nodes are round or enlarged, they're almost always pathologic rather than reactive. And it's important to pay attention to this region because unless you window this area appropriately, the streak artifact from the surrounding bony structures will often make this area uninterpretable. So again, pay special attention to that, especially if you're dealing with a laryngeal cancer or, say, thyroid cancer, as they can have Mets to this region. So that leads us into discussing common nodal drainage pathways from various head and neck cancers' primary sites. So for a nasopharyngeal primary cancer, you will often find lymph nodes in the retropharyngeal regions or retropharyngeal lymph nodes that are pathologic, as well as level 2 and jumping inferiorly to level 5 lymph nodes. So just really pay attention to your retropharyngeal nodes, level 2 nodes, and then again, it may skip levels right down to level 5, or right back to level 5, rather. We have oral cavity cancers. So these are going to be usually small rounded nodes, and the drainage pathway for the oral cavity starts in the segmental and submandibular, so that's level 1A and 1B nodes, and then moves down the chain to level 2 and level 3 jugular-digastric chain nodes. It's important to note that sometimes you can skip levels, skip level 2 and go directly to level 3 lymph nodes from the oral cavity, so it's important to pay attention to that. Oral pharyngeal primaries tend to follow the drainage pathway going from level 2 down to level 3 and potentially more inferiorly. Laryngeal cancers will usually start at level 2 and level 3 again, but involve your central compartment nodes such as level 6 and also move inferiorly into mediastinal nodes. So you may see lower mediastinal nodes before you ever see nodes in lateral neck level 4. Thyroid cancers will involve level 3 and 4, as well as your central nodes and your retropharyngeal nodes as well. So when you see a thyroid cancer, it's important to actually look back at the retropharyngeal nodes in order to not miss nodal metastases there. When you have skin primaries, as we had already discussed, you will have parotid, preauricular, as well as posterior cervical lymph nodes. If you have an isolated supraclavicular or inferior level 4 or level 5 node, the primary disease is likely not in the head and neck. So this is when it's important to alert the referrer that this patient may have a primary elsewhere, such as in the lung or in the breast. So what constitutes a pathologic node? Well, in summary, in essence, the morphology of the node trumps size every time. So you can have a very small node, and if it is centrally necrotic or abnormally enhancing, that node can be pathologic, even if it's not quote unquote enlarged, even if it's just a couple millimeters in size. So morphology in terms of if you have anything necrotic or cystic, if you have a hyperenhancing node, or if you have a round node rather than the nice kidney or reniform shaped node, those are all going to raise alarm bells in your head on whether or not this could potentially constitute a pathologic node. So, for example, on this image, if you look at it for a while, you may see that there is a level 2B lymph node over here that's quite small, only 8 millimeters. But if you look, there's a small area of central low density within that node. And indeed, this was a pathologic necrotic node that demonstrated elevated FDG uptake on PET. And despite its small size, it is most definitely pathologic. Nodes which are clustered or asymmetric can also be pathologic. These are a little bit harder sometimes to appreciate because it requires you to potentially, for example, look at a coronal image. This is a melanoma patient, and if you look at the left neck, you can appreciate a number of level 3 and level 4 lymph nodes that are clustered and asymmetric when compared to the contralateral side, and these are all indeed melanoma mets. In order to recognize a pathologic node early, one trick that you can do is pay attention to the contour of the jugular vein. This is a patient with a oral tongue squamous cell carcinoma primary, and if you look in the right neck, there is a very small node, by itself not necessarily pathologic, but look at how it's indenting the anterior margin of the jugular vein. And this is a bad sign. A normal node will not have this kind of mass effect on the surrounding veins. And indeed, when the patient returned a few months later for a follow-up, we see that node has considerably increased in size and is demonstrating internal heterogeneity and hyperenhancement. And indeed, this is an example of a pathologic metastatic lymph node. So when we are looking at nodal staging for head and neck cancer, according to the new AJCC8 criteria, most of them are going to have the same nodal staging scheme, all except for nasopharyngeal cancers, as well as for P16 positive HPV associated oropharynx cancers. So let's look at the nodal staging for most head and neck cancers. This chart can be used for oral cavity primaries, laryngeal primaries, hypopharyngeal primaries, as well as HPV negative oropharynx cancers. When we're looking at this chart, we notice that one of the biggest markers is this idea of extranodal extension, that if you have any extranodal extension in any node, it gets upgraded to N3B disease, the worst staging, if you will. If you have ipsilateral nodes that are between 3 and 6 centimeters, you get N2A staging, which is upstaged from N1. And if you have multiple ipsilateral nodes, that's N2B staging. And if you have contralateral nodes, that is N2C staging. So what is an example of that? Here we see a left lateral tongue cancer, which belongs to the oral cavity subsite, and therefore we're going to use that chart that we just saw to stage any lymph nodes that we see in this case. On this axial image, we appreciate on the right, this is below the hyoid, but above the inferior margin of the cricoid. In fact, you can see the upper margin of the cricoid right here. So this is going to be a level 3 lymph node that looks clearly necrotic. And because it's on the right side as opposed to the left side, this is a contralateral metastasis. So the nodal staging here is going to be N2C disease because we're involving contralateral lymph nodes. What about here? This is a patient who has a supraglottic larynx cancer. You can see here this abnormal enhancement and FDG uptake involving the left aspect of the epiglottis and area epiglottic fold. And just adjacent to it, you have a large level 2 node, which is hyperenhancing and also demonstrates increased FDG uptake. And there you see a very irregular margin with the overlying sternocleidomastoid muscle. And this is an example of extranodal extension, which will upstage this nodal disease to N3B, even though it is an ipsilateral lymph node. What about nasopharynx cancers? You can see that this nodal staging chart is completely different from the one that we just saw. And it's just, rather than memorizing all of these details, it's just important to remember in your head that if you have a nasopharynx cancer, you're going to use a different staging scheme. And therefore, when you're looking up the staging charts, to really remember to not use the most common one that's applied to the other head and neck squamous cell cancer sites. So for nasopharynx cancers, we have two things that really make the difference. One is whether or not you have contralateral nodes. So if you have ipsilateral nodes only, or ipsilateral or bilateral retropharyngeal nodes. So the retropharyngeal nodes are basically considered more central. So if you have ipsilateral or these central retropharyngeal nodes, that's N1. If you have bilateral nodes or contralateral nodes, then that's N2. But if you have any low neck nodes, that is anything below the caudal border of the cricoid cartilage, so essentially any nodes that are level 4 or level 5B, those are going to be considered N3 nodes, as well as any lymph nodes that are bigger than 6 centimeters. What about oropharyngeal cancers that are P16 positive or HPV associated? Those also have a different nodal staging criteria because these cancers tend to have a better prognosis than most of your other head and neck cancers. So this is what we use. If you have multiple ipsilateral nodes, as long as none of them are bigger than 6 centimeters, that's N1 disease. If you have bilateral or any contralateral lymph nodes, again, nothing that's bigger than 6 centimeters, that's N2 disease. And if you have anything bigger than 6 centimeters, and these have to be in the greatest dimension, that's N3 disease. So when you're measuring these lymph nodes, if you see a large node and you're trying to decide how to stage it, always measure it in the greatest dimension. If that is in coronal or sagittal measurements, use those measurements rather than just based on your axial imaging, because that's going to change nodal staging criteria and how the patient is treated. So what about if you just see a big neck mass and you biopsy it and it turns out to be metastatic squamous cell carcinoma, but you really don't know where it came from? Well, in most cases, the primary will be oropharyngeal in origin, such as specifically from the tonsils or tongue base. Just statistically, these are most common likely subsites to be the cause of the nodal metastatic disease. So when you biopsy the node, you should send it for P16 testing. And if it is P16 positive, that suggests that it's HPV related. And we must then confirm that by performing the more expensive and involved HPV PCR testing. And if that's also positive, we're going to presume that this node is from an oropharyngeal primary. At that point, the head and neck surgeons will biopsy the oropharynx on the same side as the node, or perform a total lingual or palatine tonsillectomy in order to try to identify the primary site. If when you biopsy the node and you send it for EBV testing, that turns out to be positive, we're going to presume that it's a nasopharyngeal primary, because nasopharynx cancers are the ones that can be associated with EBV positivity. If the node is biopsied and it's both P16 and HPV negative, then this is going to be a true unknown origin primary, and they're going to perform a set of treatment protocol that's designed to address this idea of the unknown origin squamous cell carcinoma in the head and neck. So what do you do when you're faced with a cystic neck mass? When you're looking at peds neck radiology, often people want to suggest branchial cleft cyst if it looks very simple and cystic. But the one thing that you must remember is that for adults, a cystic neck mass is almost never a branchial cleft cyst. More commonly, when you're faced with an adult patient, these are going to be metastases from a P16 positive or HPV related oropharynx cancer, or a metastasis from a papillary thyroid cancer. These are much, much, much more common than a branchial cleft cyst, which will generally present before people reach adulthood. So again, we must presume that a cystic neck mass in an adult is a necrotic nodal metastasis until it's proven otherwise by excision. Why do I say by excision? Is because these cystic nodes, when you try to biopsy them or aspirate them, often you may not get a good yield because you're going to end up with necrotic contents. So for example, here are two cases. On the left here, the question is, one of them is a branchial cleft cyst and the other one is a necrotic lymph node. So on the left here, you have a 19-year-old kid with what looks like a pretty complex looking cystic lesion in the left neck between your sternocleidomastoid muscle and your submandibular gland. On the other hand, you have a 55-year-old patient with a more simple looking mass that also appears centrally cystic, also located in a similar position between the sternocleidomastoid and the submandibular gland. Well, as it turns out, even though this lesion looks more complicated, the 19-year-old had a branchial cleft cyst, while the 55-year-old had a cystic nodal metastasis from an oropharyngeal primary. So again, let age help you, and in an adult, it never assume that it's a branchial cleft cyst until you've proven otherwise. Okay, so in the last few minutes, we're just going to quickly overview some other causes of cervical lymphadenopathy. So remember that when a patient presents with palpable neck nodes, one quick question that you want to ask is, how long has it been there for? If the patient has had some upper airway respiratory infection and it's only been about a week or 2 weeks, these can very commonly be reactive lymph nodes, in which case you can ask the referrers to follow these nodes clinically and re-image if they persist beyond the expected 4 to 6 weeks. But first, of course, you want to search the rest of the scan for any signs of a head neck primary squamous cell carcinoma. Other common causes of cervical lymphadenopathy include lymphoma and sarcoidosis. And then you want to see if the nodes are either hyperenhancing, calcified, or low density, because these can guide your differential a little bit, these imaging characteristics. But as it turns out, that most likely, if there is persistent lymphadenopathy that's not going away, you will likely need biopsy in order to confirm the pathology for head and neck lymphadenopathy. So just for some examples, lymphoma in the neck is usually solid and bulky, as you can see in the right neck here, but sometimes they can become cystic and necrotic after treatment or after being super infected. And although they tend to be bilateral, as this is a systemic problem, they can present unilaterally as shown here. And this is an axial image of another patient, again showing these homogeneous bulky nodes in the right level 2B and level 5. And this is another example of lymphoma, even though it's fairly asymmetric. What about sarcoidosis? Sarcoidosis is a systemic granulomatous disease. And again, you're going to usually see symmetric lymphadenopathy, and it can closely mimic lymphoma. And here you want to check for parotid lymph involvement because sarcoid can also often involve the parotid glands. If a node is hyperenhancing, there are a couple of things that pops to the top of your differential list, one of which is a thyroid cancer metastasis. So you can see in the right neck a very hyperenhancing lymph node over here. Another is Kaposi sarcoma. This patient has very diffuse anasarca and edema, but standing out against those, you see these very hyperemic, hyperenhancing lymph nodes, and this was biopsy proven to be Kaposi's sarcoma. And then a whole host of other diseases that are rarer, including Castleman's disease, which is also known as angiofollicular lymph node hyperplasia. And that's what's being shown here. You have these homogeneously enhancing, hyperenhancing lymph nodes. Other even rarer considerations include Kikuchi's disease, which is histiocytic necrotizing lymphadenitis, and there you're going to see usually necrotic lymph nodes, and Kimura's disease, which is a chronic inflammatory disease that's benign, and there you're going to see more uniformly hyperenhancing nodes, typically involving the parotids. What about nodes that contain dense calcifications? When you see that, medullary thyroid cancer metastasis comes to the top of your list, as does granulomatous disease such as TB and sarcoid. Treated infection and treated lymphoma can also have this appearance, and these are examples of bulky medullary thyroid carcinoma mets in the left neck, and also you can see the primary in the left thyroid gland. What about low-density nodes? So here you see these very heterogeneous, centrally low-density nodes. Lymphoma, sometimes treated lymphoma, can have this appearance. Squamous cell carcinoma mets, as we've seen, can often be necrotic. But another thing that you want to think about are atypical infections when you see this appearance, such as TB and mycobacteria, and cat scratch disease, and other fungal causes. And this turned out to be a case of histoplasmosis causing diffuse low-density cervical lymphadenopathy. So in conclusion, we reviewed cervical nodal levels. We looked at the nodes that are not within levels and why it's important to identify them, especially your periparotid, your periauricular, your intraparotid, as well as your posterior cervical lymph nodes, which can come from a skin primary or a scalp primary. We looked at common nodal drainage pathways from various aerodigestive tract subsites, and we went over what constitutes cervical nodal pathology. And again, morphology is much more important than size. We reviewed nodal staging for head and neck cancers. Remember, for most of your head and neck cancer metastatic nodal disease, you have one staging scheme, but nasopharynx cancers and HPV positive oral pharynx cancers have their own staging criteria. And finally, we looked at causes of lymphadenopathy other than squamous cell carcinoma in the neck and how you can use the imaging characteristics such as hyperenhancement and calcifications to help guide your differential. Thank you so much for your attention.